All right. Well, I have some housekeeping stuff to go over, so we'll do that while some people are still joining, but we want to get started right away. So on behalf of the Epilepsy Foundation of Wisconsin, we want to welcome you to tonight's virtual meetup call. Tonight's topic is, as you see on the screen, neuromodulation for epilepsy. So the housekeeping things, like I said before we get started, we are recording this, so you can find it on our website by early next week. If you go to epilepsywisconsin.org and you click the video library tab, we have an updated page. It looks really great. Thank you, Kristen. If you're on this call, you did a great job. You can go there and watch the recordings from previous weeks as well. Also, attendees on this call tonight, please know that you are muted and your videos are also off. But we do encourage you to ask questions throughout Dr. Sandok's presentation, or if you want to wait for your questions at the end of the call, that's fine too. You can do that by using the Q&A button wherever it is on your screen. It's on the bottom of my screen here, but you can locate it on your screen, and that's how you can submit questions. John and myself will be monitoring those. And then just know, for sake of time, we may not get to all questions this evening. So if you think of something after the fact, or your question just wasn't able to get touched on this evening, you can use our connect@epilepsywisconsin.org email. And I see John is putting all of the information I'm saying into the chat for you. So please feel free to use that email if you have additional questions, and we'll get the questions to Dr. Sandok. And then the very last thing before we get started is we do have a short survey following this, the virtual meetup. It's just 3 short questions. If you find that you have a few minutes when the call is done tonight, we appreciate the feedback. So please do take that if you have some time. All right, so we'll get started. So introductions. My name is Alicia Thompson. I'm the program manager for EFW. We also have John on the call. John, if you want to say hi.
Good evening, everybody. John Mirasola. Work with Alicia at the Epilepsy Foundation and primarily deal with communications and client services support.
Great. Thank you so much, John. All right, so I'm going to turn it over to Dr. Sandok. He is a neurologist at the Marshfield Medical Center. Dr. Sandok, thank you so much.
Thank you. Thank you, Alicia and John. Okay, I don't know who's out there, and again, I can't see the chat, so they'll sort of chime in and let me know if things aren't going well, but I'm here to talk a little about neuromodulation, which is kind of the term I use for different ways to use electricity to treat seizures. I'm going to begin by just doing a few disclosure things, again, and sort of housekeeping. I was involved with the DBS, or Medtronic Santé study, which was the study that led to the FDA approving that, but I haven't received any financial incentives from any of these companies. And no other disclosures of importance. I'm going to just begin pretty basic. So most of us, I think, would be comfortable with saying that epilepsy is a central nervous system disorder, which brain activity becomes abnormal. Again, this isn't rocket science here, but I just want to make sure we're all starting on the same page. When we're talking about epilepsy, I usually try to explain to people that I try to put it into 2 groups. What we typically refer to as primary generalized. Now there's new terms, but this is what I tend to use, or genetic epilepsy and inherited epilepsy, versus what we refer to as an acquired epilepsy. And this is more common epilepsy. This is epilepsy that comes on typically in adults, though children can have both types, or older people, again, would be acquired. And again, there's typically used the terms partial or now focal epilepsy, and then without generalization. And that's actually important because the neuromodulation is only approved, depending on the type, for certain types of epilepsy. So you actually have to know which type of epilepsy we're talking about. In general, we usually use this when we're talking about intractable epilepsy to point out that 70% of people with epilepsy will be seizure-free with one medication, the first one they try, whereas 30% are intractable. And then, of course, people who treat people with epilepsy spend most of their time with that 30%, not in the 70%. If we look at the mainstay of what we do to treat people with epilepsy, the mainstay is medications. This is how I spend most of my day using with all of these medicines. I have people on every one of these medicines. I have people that have done well on every one of these medicines. I also have people that have done poorly on these medicines. This is still the mainstay of what we do, but for some people, we don't get them seizure-free, or we don't get them where they want to be. by using medication. And I suspect many of you will recognize many of these medicines. Again, these are the generic names, but many of you are familiar with those. So if you look at someone who has tried 3 medications, there was a physician in Scotland who looked at this and said, what's the chance that the 4th medicine was going to work? And it was pretty small. It's only in the 9 to 10% chance range. Now, it doesn't go lower, but that means that for someone who's tried 3 medicines, each additional medication has a relatively small chance of getting them seizure-free. So what are your options then? Well, if someone's tried several medications, they should always discuss the possibility of epilepsy surgery. Now, if there is a focus that can be identified, and again, if you have primary generalized epilepsy, which we'll come back to again, usually this isn't an option. But for people with focal or partial epilepsy, potentially this is an option. And if the focus or where the seizures begin can be recognized and can be recognized as being a place that's safely removable, then surgery can often be offered, and that can offer as much as a 70 to 90% chance of being seizure-free. Okay, but what if you can't find where the seizures come from? What if you have more than one focus? What if the focus can be identified, but it's not safe to take it out? It potentially would cause a permanent and noticeable deficit. Or what if I have primary generalized epilepsy? Then you can't offer those options. When I talk to people about different types of epilepsy, I usually use the analogy of throwing a pebble in a pond. And people say, what? But if you throw a pebble in a pond, then the waves go out kind of like in this photo. And depending on where you threw the pebble and how big the pond is, the waves might hit the edge of the pond differently. So this is obviously, I don't know, can you guys see my cursor? Is that, Alicia,
Yep.
can you guys, okay.
Yes. Yep.
So if we imagine throwing a pebble in a pond and we threw it over here, the waves would go out, but they would hit this side way before they would hit this side. As opposed to if we put it here, potentially the waves would go out, if you could imagine round waves, and they would go out to all of these places all at once. If we imagine little boys standing on the edge of our pond, and when the waves get there, they would put their hand up. Well, the boy that stands right here would put up his hand way before perhaps this boy, and this boy may never put it up if the waves never make it there. Electricity, as we think of it, seems to move somewhat like that. So with people with partial or focal epilepsy, we see an electrical change close to where the focus is, and we may not see it on the other side. Whereas people with primary generalized epilepsy, we tend to see an electrical disturbance in all of the EEG at once. So when they do an EEG, sometimes when someone has first started having seizures, they're trying to differentiate this. Again, when we see primary generalized, we often think about a genetic cause. When we think partial or focal epilepsy, we tend to think of a more structural cause that we might be able to find that was acquired, perhaps an injury, perhaps a tumor, perhaps, a birth defect. Now, even in this day and age with very, very, very good MRIs, we often don't find that abnormality, which is disappointing. But sometimes, in fact, saying you don't have a brain tumor is a good thing. But it is somewhat unsatisfying to say, I know your seizure comes from this area, but I can't tell you exactly why. I can't see that cause. But that's the first differentiator when you're talking about what type of epilepsy, if you will. Now, again, if we go back to primary generalized, surgery isn't really an option for this because there's usually not a lesion, there's not a tumor, there's not a scar. And for those people, in fact, some of the medicines that work for partial epilepsy can actually make it worse. So for them, in fact, there's a relatively limited number of medications that have been shown to have efficacy or working. But in fact, I could do another list of medicines that often make it worse. So for some people, again, that differentiation, these medicines didn't work, but if you were using medicines that were for the wrong type of epilepsy, sometimes we don't really expect them to work. Though I would absolutely tell you that I have people that didn't follow the rules and have a medicine that shouldn't have worked, but did. I'll keep going again. So for people that have intractable epilepsy, the ketogenic diet remains an option. Many people think of this as only a treatment for children, but I believe we have something close to 20 or 25 adults in addition to the children that are on this. And the reason they do it is that it tends to work. It tends to be a very effective treatment for epilepsy. We typically suggest that at least 50% of our patients see a 50% reduction in their seizures. Now, it isn't easy. The shorthand is no bread, no pasta, no cookies, no fruit, no soda. And if I haven't put you off by that, then we can talk. But if I have, then we don't do it. It is difficult to tolerate. We expect to see a small increase in the cholesterol or lipids, but in some people, it's larger than a small increase. And that is something that's concerning. We do have a risk of kidney stones, and that's something we have to watch for. Okay, so what else we got? Well, for some people, we do talk about autoimmune or paraneoplastic causes. And for those people, we don't necessarily use seizure medicines such as I've mentioned before, but sometimes we use immunosuppressant medications to try to cause a reduction in their immune response. And then we get to pacemaker devices. See, I did get there. There are 3 pacemaker devices. I'm going to try to continue to refer to them in this order because this is the order that they were FDA approved. The vagus nerve stimulator, which we will typically refer to as the VNS, the responsive nerve stimulator, which we will typically refer to as an RNS, and the deep brain stimulator, which we will typically refer to as a DBS. Now, why did we come up with this? And it was people much smarter than me, but the idea, there's several different ways to approach it. First of all, nerves send electrochemicals through, and we really, when we think of chemicals moving from one place to another, that's really very much like a battery. Batteries involve movement of chemicals from one place to another. There's a positive and a negative plate. There are chemicals moving between. Most batteries, if you think of in your car, have liquids, right? They're acids, there's metal plates, and again, it's moving of ions, components of the battery. Well, in fact, in nerves, they send signals through passageways, which we refer to as channels. And some of these channels are in fact sometimes thought to be functioning incorrectly. Some of the causes of seizures are when channels aren't working particularly well, and the seizure medicines tend to work on these channels and cause some of them to partially close. Some particular medications work on the sodium channel, which is the Na, or the potassium channel, which is K. And there's other channels that we use. Okay, I doing something not quite right here, but I'm not sure why. So again, we tend to think of seizures as abnormal electrical discharge. If you think back to my waves, when I threw the pebble in the pond, the waves spread. And in fact, we can see that on our EEG. So things begin and spread and they get bigger. Now, this is a little hard to appreciate, but things are changing here on the EEG in several different places. And again, this is another one where it sort of expands and then gets much bigger. It's a little hard to appreciate, but I think you could say that this would be kind of like maybe the first wave of our pebble, the second wave, third wave, and then eventually the waves dissipate. Perhaps not exactly what we're talking about, but pretty close. You get the idea. And they've known that the brain has electrical activity they can measure since the 1920s. Now, if we go farther back, in fact, if we go way back in the 1st century AD, a Roman physician came up with the idea of using electricity to treat headaches and gout. Now, for those who are not familiar, torpedo fish is, I guess, somewhat like an electric eel, except he's a fish that has electricity. I'm not sure if it worked for these things, but it does give people a shock. There's actually a pretty famous Italian scientist at Galvani, where we get galvanic measurements. His name was used, and he actually suggested that animal electricity was the animating life force, and this was back in the 1700s. For those of you who are curious, this probably was the inspiration for Mary Shelley's book Frankenstein, which many of us have seen the movies and such. There was some rather difficult studies that were done in the 1950s and 60s, and I say difficult because there's some ethical concerns. There was a physician, he was a psychiatrist, who did these experiments on people where he implanted electrodes, and he actually did it in 50 people, and he was trying to look at emotion, particularly pleasure and reward. And there was a number of concerns as to whether these people really gave informed consent. Nowadays, there are things that are simply not allowed in research. You must make certain that the people who are being studied appropriately understand the risks involved. And there was some significant concerns as to whether the people he chose for these studies really agreed to do them or were forced to do them. He did try something called a homosexual conversion of a gentleman who was homosexual with electrical stimulation. And it's actually a kind of disturbing study to read in terms of the processes that he went through. And it's not clear that it actually came up with anything useful. He also used prisoners, which in this day and age is considered absolutely forbidden to do. You can't do research on prisoners at all for fear that they are doing it to try to get better treatment, rather than in people, when they do experiments, have to be fully understanding that they're in theory not getting any benefit or potentially not getting any benefit, and they're doing it to help other people. And again, there's a lot of questions in terms of, some of you may have been involved with studies, and there's a lot of questions about, do you understand this? And those people potentially didn't. Now, as we move a little bit later, in the later 1960s, there's some really amazing studies were done by a Dr. Delgado. He actually placed some electrodes in the brain and in a bull, and he had a bull charge at him. I have to be perfectly honest. I tried to get the YouTube video to work, but I couldn't. You can look this up, but I'll show you what he did. He had a remote control device, and the bull charges at him as he's holding the matador's cape, I guess, but he also is holding an electric stimulator. He then stimulates, and the bull stops in charge. It stops charging and actually turns away. Now, exactly what the bull felt, or why was it pain? Was it actually, if you watch the video, he turns his head, so you wonder if he caused the bull to have a motor manifestation or motor change. But the bull did turn away from him, and he didn't get hit. And they did this several times, so this was not just one time. So they began to realize that we might be able to change the way the brain works with electrical stimulation. So then the question is, where do you stimulate? Now, I like analogies. Sometimes my wife and my patients and my assistants at work always say you give too many different stories about this. But let's imagine you're trying to stop a car. If the wheels are going too fast, you could either, let's pretend it's one wheel that's going too fast. You could grab the wheel. That would be analogous to trying to stimulate near where the seizure is occurring. So it would be a local stimulation. So let's imagine that there is a small focus, an electrical focus. We find that, and we could stimulate that area directly. Again, like grabbing the wheel of a car that's going very fast. Alternatively, in our car, rather than grabbing the wheel, we can take advantage of a connection that goes throughout the car and goes to the brake pedal. I could press the brake pedal, And it does, through a series of connections, connect to that wheel and hopefully stop the wheel from turning. Now it goes other places too, but I'm taking advantage of a connection that's already there. So again, I could use something that connects to where the seizure comes from. And I'm not touching the area directly where the seizure comes from, I'm touching it indirectly. I'm not grabbing the wheel to stop it. I'm pressing the brake pedal. Again, for our people with focal or partial epilepsy, this appears to be something that can work. It also appears that this may work for the primary generalized, the people with inherited epilepsy. So the vagus nerve stimulator was the first of these pacemaker devices which was approved. It was approved in 1997. It has been approved for other things, which again, I will just touch on. They're not really why we're talking, but the VNS or vagus nerve stimulator has been approved for depression. In Europe, it's approved for pain. And another VNS device, so this is interesting because again, it's a non-invasive, and the one that's approved in the for epilepsy is invasive. We'll talk a little about that. Has been approved for cluster headaches. The responsive neurostimulator, and again, we'll talk a little about what the differences are, was approved for epilepsy and only the epilepsy in 2013. And the deep brain stimulator was approved for epilepsy in 2018. But prior to that, in 1997, it was approved for tremor, but in a different location. The stimulation occurs in a different location. For Parkinson's disease in 2002, again, a different location in the brain, as well as dystonia. And then in 2009, it was approved also for obsessive compulsive disorder. So that device is used for other things. And you may have met someone or know someone that has a DBS that doesn't have epilepsy. So again, there's the vagus nerve stimulator. There is a generator, or the device where the battery is. There's a wire, and then it connects to the vagus nerve in the neck. There is the responsive nerve stimulator. That was the second one. This actually has a generator up here in the head, and then wires that will go off from that. And again, the battery is with the generator. And then this is the deep brain stimulator. So again, the generator or battery in the chest, wire travels up, and then the wires go deep inside the brain. Whereas these sit on top mostly, though this one does show that one that goes inside the brain also. And on this one, this just goes on a nerve in the neck. So the vagus nerve stimulator, a little bit closer look. So again, we have a generator, and there's actually several that are slightly different shaped, but this is the latest one. Again, there's the generator or with the battery inside. And actually, the majority of this is in fact battery. The computer is actually very small. The device is titanium. It's very light and very strong. And then the wire travels under the skin. It doesn't have to have these curly cues, but they're nice looking. And then it attaches here to the nerve. These people end up with a scar here in the neck and a scar here. And this wire is snaked under the skin without making a connection that you see. The responsive nerve stimulator has a slightly curved device. You'll see it a little bit better in another picture. And this, again, has the battery and the computer. And this one's a little fancier computer, which will explain that this one it works slightly differently, but then it has wires that connect off, and they can either go on the surface or inside the brain. And again, the deep brain stimulator. Now, this particular one, they've placed two, but you don't have to. You actually can connect both of these electrodes, which go into the brain, to one, or you can do it with two. And some would argue that two gives you a longer battery life in each one, but it's also a little bit more complicated. Most people, I think, use two wires into one generator or battery. So again, where do we stimulate? The responsive neurostimulator. This is like grabbing the wheel on the car. the stimulation occurs at the place where the seizures occur. The network or away, that's the VNS and DBS. With these, we are either stimulating the thalamus with DBS or the vagus nerve, which is down in the neck. And then that connects via a network to where the seizure comes from. Okay, so how do you approach which one to choose? Well, let's go back to what we talked about first. You first have to figure out what type of epilepsy does someone have. If it's a primary generalized, that may change what we do, but if it's focal epilepsy, we then figure out, is it intractable? If someone can control their seizures with medication, then they probably don't need to go any further. If someone can't control their seizures with medication, then they really should look at whether surgery is an option. Surgery really should be considered before looking at any of the pacemaker or neuromodulation devices. If surgery is an option, we would suggest doing surgery. It has a better chance of becoming seizure-free. If it is not an option, either we can't find where the seizures come from, or we have multiple places where the seizures come from, or we can find it, but it's not safe to remove it, then we should consider one of the neuromodulation devices. The VNS, as we talked about, that does not have a hole in the brain. It has a device in the chest and connects to the nerve. So if someone is not interested in surgery that goes into their brain, the vagus nerve stimulator is an option. The responsive neurostimulator is actually very interesting because it's not just a stimulator, it's actually a small EEG machine. The wires actually record EEG and they look for seizures. So this device actually records EEG. So if someone wants to know, gosh, how many seizures do I have? The RNS actually can do that, and there's some steps that you download the information that it records on a regular basis to the cloud. And your doctor can look at that, as can the people at the company that makes the device. So the RNS device is certainly an option, especially if you would like to try to figure out how many seizures does this person have, because it can actually show you, it keeps a record. And sometimes the record is exactly the same as what you notice. Sometimes it's not. Sometimes it can record things that you haven't noticed. If you can't find the focus, you don't know where the seizures come from, then you can't use the RNS, because the RNS requires placing those wires over where the seizure comes from. So if you can't find that, then the DBS or the VNS is still an option. Or if there's multiple different sites, usually DBS or RNS, though there is the option to do the RNS with 2 different wires. I think I showed that in the picture. Go back. Yeah, here. So this person presumably has 2 wires with 2 different foci. Okay, sorry, jumping ahead again. Or again, if it's an area that you can find the spot, but you don't think it's safe to remove it, the RNS is a very nice choice. So again, there are reasons to choose each one. Now, we move on. The VNS, again, vagus nerve stimulator, goes in the neck, is indicated for partial and focal refractory epilepsy. And again, this may be useful for primary generalized epilepsy. Remember, we talked about it uses the network. It doesn't necessarily have to grab the wheel, if you will. The RNS is for refractory epilepsy with single or multifocal onset, but partial epilepsy once again. And the DBS so far is just for refractory partial or focal epilepsy. These are based on what they've tested them on. Now, we absolutely know that people have used the DBS for primary generalized. We know that they've used the VNS for that. The RNS, probably not. Again, that requires finding the one spot. And if you remember, we talked about throwing the pebble in the middle of the pond. For people with primary generalized epilepsy, they see the abnormality everywhere at once. So the computer wouldn't know where to quite put the wires for that. That makes sense. So how well do they work? If you remember, we talked about the surgery, and if they can find the right spot, and that spot can be safely removed, the chances that surgery may work is somewhere between 70 and 90%. But we use a different measurement when we're looking at the vagus nerve stimulator, responsive nerve stimulator, and deep brain stimulator. The vagus nerve stimulator, typically they look at a number that would see a 50% reduction. And they felt that was about 30 to 40%. And if you remember when I talked about the ketogenic diet, that was 50%. So it's not quite as good as the ketogenic diet initially, though they believe over time that they've shown that that would increase to 40 to 50%. But it's a lot easier than the diet. You still get to eat cookies and potato chips, which you don't get on the diet. So this is somewhere between 30 to 40% and may increase to 40 to 50%. RNS, that's the responsive neurostimulator, that's the small computer in the head. Again, about 40%, but it appears that over 7 years when they did the study, the efficacy, the number of people that saw at least a 50% reduction, improved to close to 70%. And with all of these, a small number of people do become seizure-free, but it isn't a high number for any of them. The deep brain stimulator appears to have nearly identical numbers, though it works again. This one was like grabbing the wheel. It's local. This one is a network. This was stimulating in the deep part of the brain, in an area called the thalamus. But again, 40% initially in the reduction. So 40% would see a 50% reduction in their seizures. And then over time, that came as high as 70%. And a smaller number, again, of these people saw even better results, and a small number in the studies became seizure-free. So how do you place these? Well, they're all surgery. The VNS, though, it does not require intracranial surgery. It's typically either done as an outpatient or a brief inpatient procedure, depending on the place and depending on the person. Again, as we remember, showed the drawing, the generator or battery goes in the front part of the chest. It's under the skin. You would feel it if you ran your fingers across the skin. You would feel it under the skin. The wire travels under the skin to a nerve in the neck, and then the wire is wrapped around the nerve in the neck. So this is actually an older model, but just to show you what the device looks like, it's sort of a gray with a plastic. The wire goes into this section here. Here you can see it again. So again, there's the generator, the wire that travels under the skin. You don't see that. And then the nerve actually has, it's kind of interesting, the nerve itself has a funny, like a pigtail. It wraps up like a curlicue, and they wrap it around the nerve itself. This is a picture. It's actually an X-ray. This is like of the chest. So this is the heart. The head is up here. You can't quite see it, but you can see the generator. If you look carefully, you can actually see the wire. And here, you can't quite see it, but that's where the nerve has the wire wrapped around it. So the responsive neurostimulator, remember this is a small EEG machine. So it's a small EEG machine that has to be taught what your seizures look like. But the EEG machine is placed in the skull. So this is the small EEG machine. They cut out a hole to place in the skull, sort of curved. You might be able to see that. And then the wires will attach to that. You can see a pencil in dimes. You get a chance to see the size. Now, it does stick up just a little bit. So if you ran your fingers, they would, remember, be making a hole in the skull, and it sits in the hole. So you can see here, the generator or battery is here. The wires are now inside. You won't see them. You don't feel that. If you ran your hands over the head, you could feel the scar here, but there's only the one scar. If we take a X-ray of the face, of the head. This is someone looking at us, and you can sort of see it right there. And you can sort of see the wires. But if we look at it from the side, so I'm sorry, this is a nose. Here's an upper jaw, lower jaw. Then you can see the lips, the back of the head. So here's the generator. It's sort of curved. And here's one wire there, and there's the other wire there. Again, the responsive neurostimulator, this one shows that it actually has a funny little basket that the little generator sits in with little legs off the side just to make it easier for the surgeon. There's the wires. And the DBS, again, surgery. This one is done in the hospital, and they place deep brain stimulation electrodes. These are wires, and they're placed with a computer in the operating room to be very precisely in a very deep part of the brain, which previous studies have suggested that if you stimulate that area, again, it's kind of like tapping the brakes on a car. The generator, which is connected, is in the chest. So here's the generator. The wires will attach in here. Again, they tend to make these out of titanium because it's light and very strong. This again is a picture I showed you before. This is a generator. The wire goes under the skin, so you'd have a scar here on the chest. Again, it's not in the chest, it's under the skin. You would feel it if you ran your hand across the chest. The wire travels under the skin, behind the ear, under, and then there's another incision here. Sometimes there's an incision right there, a very small one where they have that connector. And there's an incision here, and again, most centers connect these two together. But then you would be able to feel this. In fact, this has to make kind of a curve, and so they have this little button to what they call stress relief. But you can feel that, and in some people it sticks up just a little bit, and with the two of them, I have several people who've suggested to me that looks kind of like a beginning of horns, but they're very small, and but you can feel them. Again, the wire travels down into the brain to this area called, this one's actually says the subthalamic nucleus, but that's for Parkinson's. For epilepsy, in a slightly different spot over here instead of over there. Here we have some x-rays. So this is the head. Again, someone looking at it. You can see the electrodes on both sides. You can see the wires. This person has both wires coming off the same side. Again, this is the head from the side, so their face would actually be right here. This is part of the jaw, but you can see the wires here. And then this is the wires that come down in the neck. Here they're coming farther down into the chest, and here's the generator. So again, here's the heart. Okay, so there is again another distinction between them. If we talk about what's called open loop programming, if you have a cardiac pacemaker, most pacemakers that people think about, they give a beat. It's kind of like a metronome. It paces the heart. It goes on and then it goes off, on then off. Imagine again a pacemaker or a metronome. Click, click, click. You set it. And in fact, you can set it to do that forever. And if you set an alarm on your house, I guess a lot of alarms are smart and they know the difference between weekends, but let's imagine that you just set it to go off at 7 every morning. It would keep doing that and wake you every weekend, Saturday and Sunday if you didn't change it. But again, it's what's called open loop. It's set by a timer. Whereas closed loop, this is a slightly different kind of pacemaker. This one actually looks for a particular rhythm, and if it sees that particular rhythm, it delivers a charge to the heart. A thermostat is kind of like that. A thermostat watches the temperature, and if the temperature goes too low, it turns on the furnace. And in fact, you can have a thermostat go the other way. If it goes too high, it can turn on a different thing, the air conditioning. The VNS works by an open loop, by and large. So it works by a timer. The timer is set to turn on for a certain amount of time and provide a stimulation. Again, the VNS is in the neck. Let's pretend it does it for 20 seconds, and then it turns off for 5 minutes. And that can be set, and it will do it on and off until you tell it to stop. Now, it does have an additional feature where the caregiver can deliver an additional stimulation, or the patient, or the doctor, if the patient says, gee, I'm having an aura. So that's in response to something. So now it's become closed loop. With that way, if somebody says, gosh, I'm having an aura, and it works with a magnet that they swipe over this device, then it will provide an extra stimulation. But if you don't do that, it will just turn on and off based on a clock. Now, the newest version of this device does have an additional closed loop feature where it can watch the heart rate. And many people find that if they have an epileptic seizure, their heart rate goes up quite fast. And if it does that, this device can notice it. And if that feature is turned on, it can give an additional stimulation. So the VNS is mostly open loop, but does have some closed loop features. The responsive neurostimulator, remember, this is up in the brain, up in the skull. It's a small EEG machine. This is closed loop. It watches EEG signals and only turns on when it sees what it's looking for. So it doesn't turn on based on a clock. It turns on only when it sees what it's looking for. And it has to be taught that. The DBS is an open loop device. Again, based on a timer. It turns on for a certain minute of time and turns off. Though the latest version does allow for people to look at the EEG or look at some information in the doctor's office through it, but it really doesn't turn itself on or change when you have a seizure, though you have a handheld device that you can turn it on if you're having an aura or seizure. So again, it does have a feature to make it closed loop, but it's primarily open loop. The programming of the VNS is done with a cordless wand that the doctor holds over your generator on the chest. This cannot be done remotely, though there is a feature that can be turned on where the doctor can set it to make increases at certain time intervals. So if you wanted each week or every other week, it could increase itself. I typically don't use that, but it can be done. This is the wand, which gets held over the generator, and then the doctor can see that when they talk on a computer. The RNS has a wand also. This wand is held over the generator, but remember the generator is in your head, so you hold the wand over your head, and this connects up to a laptop that the patient has. The patient actually downloads the information. It's watching the EEG. It records that. It gets sent by this wand to the computer, and then the computer sends it to the cloud where it can be looked at by your doctor. That's typically done, and then once they've seen what your seizures look like, then you go back to the doctor's office and he programs the device with a similar wand on his computer. But you can't program the device remotely. This is, again, the device. She's holding the wand. It talks to the computer, and it's recording the EEG. The DBS is programmed once again with a cordless wand that you hold over the generator. This time, again, the generator's in the chest. It cannot be programmed remotely. An older system, which is this one, used a little funny looking computer, but now they've got one that's more like this. And the older one had a cable, but now they've got a cordless one. But again, this is not something that most people would adjust themselves, though there is a feature that is not used very often for epilepsy where the patient can turn it up slightly or down slightly. But with all of these, you can turn it off yourself. So if for some reason you needed it off, you can do that. I've touched on this, the VNS, you can get an extra stimulation if you think you're having a seizure or an aura by passing a magnet over the generator. The generator's on your chest. The RNS really doesn't have this option. The DBS, again, you have a remote control that you can push a button and get an extra stimulation. Can you get an MRI? The answer is, for all of these, the answer is yes, but the device needs to be turned off and the MRI needs to be done in a very particular way, and not all MRIs can do it. So you need to make certain that you tell the people that are talking about doing the MRI that you have a stimulating device and which one, and then they can see if their MRI can do it, if they have the right settings to do it, and they need to make certain that they turn it off before the MRI, and then it can be turned back on afterwards. Can you feel the stimulation? Most of these, the answer is no, but the VNS, sometimes people say, I do feel the stimulation in my neck, or some people have a slight change in their voice. I typically say it's like getting a scratchy voice. So the answer is typically, yes, if my voice changes a little bit and then it comes back. Sometimes it's disturbing, sometimes it's not, and it's not a lot of people that have that. For the responsive neurostimulator, again, that's in the brain, that's the EEG machine, typically they cannot feel that. For the DBS, again, that's the generator in the chest with the wires deep inside, typically can't feel that. How long do they last? For all of them, it's pretty similar at this point. The vagus nerve stimulator is somewhere between 5 to 7 years. The RNS and the VNS, it's quite variable, but it could be as much as 8, but could be as little as 1.5 years. And that's disappointing, but it depends on how they set it. If the device is set to give a larger stimulation, then the battery gets used more and quicker. Let's go back again. Remember, we talked about the two different strategies, either local, grabbing the area where the seizure is occurring and causing it, or that's the RNS, versus network, which is the DBS or the VNS. Remember, we touched on this before. You first want to figure out what type of epilepsy is it, and is it intractable? If it's intractable, is surgery an option? If it is, you really should look at surgery. It's a better choice. If it's not, then one of the neuromodulation choices is certainly an option. And again, each has some things. If you're truly not wanting anyone to do any surgery on your brain, then the VNS is a better choice. If you can't find where the seizures come from, the DBS is probably a better choice. If you can find it and it can be operated on, do the surgery, but if you can't, then maybe the RNS is a better choice. So where do you go? Well, the first thing I would say is, of course, find a provider that you trust and talk about this. Talk about, what are my options? Where should I go next? And if you don't have that kind of relationship, find it. But you want to know, what kind of epilepsy do I have? Do I have primary generalized? Do I have focal or partial epilepsy? Is surgery an option for me? What would I do to find out? I'm really scared to have any surgery. So what can I do that doesn't involve surgery? But if your doctor doesn't, or provider doesn't have those answers, there are certainly other ones that do. So ask for a referral to someone else. Whew, it's a lot. I'm going to end with just a couple of photos from the 1918 pandemic, which, if you're an interested person, the similarities to the current day is quite amazing. But they really did recognize that spit was part of the problem. And they really did recognize that masks were important. I like this one, wear a mask or go to jail. Unfortunately, that didn't work very well for them either. But masks are still important. Anyway, I'll stop at that point. And I think, do I stop sharing? Is that the best way to do it, Alicia?
Yes, you can hit stop share on your screen.
Okay.
Yep.
Okay. So I'm back.
Wonderful.
Dr.
Okay.
Spanbach, thank you very much. That was terrific. That really was. Very appreciated. Okay, well, we do have a couple questions here. So
Fabulous.
first one here. If you have two devices, is it okay to swipe to get an extra charge at the same time?
To have two devices, I guess it depends on someone that has like a VNS and a DBS. Is that what they're asking?
Correct.
Yeah, yes, you can. And in fact, there are not a lot of people that have more than one device, but if you have a VNS, that one's triggered typically by a magnet, and the DBS could be triggered by the remote control, and you could trigger both of them.
At the same time.
You could. They work differently. Again, they both work with networks, but it's not clear that they use the exact same network. So I don't know that there's a problem. Again, there's not a lot of people that have both of them.
Okay. Let's see here, another one. What activities should I avoid with these devices, if any, such as exercise?
Well, there's a few things that they do recommend, though they are very, very, very tough devices. Depending on where they place it, They're typically placed on the left shoulder. They don't with the DBS and with the VNS. Now, I do have people that are left-sided shooters with guns. Guns we don't like, especially shotguns and things like that. It's a lot of force in a very small amount of time. And actually the concern is that you would break the wires. The devices are pretty tough, but we've had a few people that wanted to do that and they put it on the other side. But really the devices are pretty darn tough. For most of our patients, we do ask them if there's some unusual thing they do where they have things laying on their shoulder. So we make sure that if they put straps on heavy backpacks or something, that we're not going to have the wires anywhere near where they put things. And again, the issue is that the wire, though it's very flexible, we don't want to have any bending or twisting that's very sharp. I do have one patient who was in a bar fight and struck in the chest several times on her device with a pool cue, and they couldn't dent it. They did some other damage, but this device did that. And in fact, they actually have a new test where they drive a car over the generator, and the generator can really handle even a car's weight now. As I said, it's a titanium, very strong. So it's not not the concern. Now, there are some things that initially they were very careful about people going in stores, some of the theft protection devices. I don't think we've ever shown that it programmed one of these devices, but you do have to be careful with magnets, large magnets. Now, in most people's lives, they don't deal with large magnets, but if it's a large, powerful magnet, we do encourage people to be careful. And if there's ever a question, the doctor can recheck the device. Again, we have some patients that I have a priest who, when he's speaking, he sometimes has changes in his voice from his vagus nerve stimulator. There's a feature where he can pause his device. So he pauses it when he speaks, and then he unpauses it when he's finished. But for most of our patients, we talk about, what can you do? Can you play baseball? Can you ride a bike? The answer is, yeah, you can do those things if you could do them before. It's one of those jokes. Doctor, can I play the violin? Did you play it before? Because it's not going to teach you the violin. Sorry.
Okay. It's another one here. How much of a chance is there that I will be able to stop meds when I go with a device?
Well, remember, we go with the numbers. So we're talking about a 50% reduction in numbers. And so let's say it was the RNS or the DBS. So it's about a 70% chance that you'll see a 50% reduction in your seizures. There's a smaller number of people that are in fact seizure-free, but for most of our patients, they worry in our patients, most of them, if they're doing well, can take less medicine, though very few take none. I would say we've had one patient who had a DBS and went off medicine, but eventually went back on some medicine, much lower than she was on before. But I would say it's a much lower number, but many of our patients take less medicine. That's one reason they do it, to try to get on less medicine.
So more likely a reduction in medicine would be more common.
Yeah. Yes.
Another one here. When you say that the RNS records the activity like an EEG in your brain, does that mean that it learns about your seizure patterns and your seizures can get better in time?
It does learn. It doesn't. It's just a recorder, but it records, and then that information is sent to the company and their fancy computer. They have a giant supercomputer that they can look at it, and their people will look at it, and they learn what your seizures look like, and then they program the device to be more sensitive. So over time, the program may change. It only gets changed when people do it. It doesn't do it on its own. But yes, it's actually recording EEG, and you can actually see it. The doctor can watch the EEG as long as you have it connected or have connected it to the cloud.
Okay. See here, another one. Are there newer devices being developed right now?
There are, and these devices they're not done with these. Each year they add different features to these. I've sort of touched on some of the features, but they're talking about doing a transcranial stimulation. This is magnetic stimulation with something that you would put on the surface, not necessarily inside the brain. There's some other devices where they're talking about stimulating other areas. I didn't include a slide, but I think there's almost 20 different spots where they're trying to stimulate in different ways, including the back part of the brain, the cerebellum. Again, different strategies, and depending on whether we're talking about local or focal stimulating where the seizure comes from versus networks. And there is some interesting ideas with the idea of tiny little pumps. So they have created tiny little pumps rather than using stimulation, tiny little pumps that would put tiny little amounts of medicine right in the area where you need it, but only when you need it. So there's some interesting ideas that they're working on.
Wow.
It is interesting, yeah. If the devices are not working for me, can they be safely removed, or do we have to live with them?
The generators can all be removed. The generators can all be removed. The wires are a little more difficult, depending on how long they've been in and whether there's a lot of scarring, I apologize. They may be able to remove most of the wire, but often the vagus nerve stimulator, it may be, if it's been in for a few years, it actually grows, the covering of the nerve grows around it. So it can be very hard to get that out. The generator in the chest or the generator here can easily be removed. In fact, it gets removed every time they change the battery. The battery is the generator. So those are quite easy to remove, but the wires are a little more complicated. And again, it does depend on how long it's been in there. So the answer is the longer it's been in there, sometimes they can move part of it, but not the last little bits without causing some tearing and bleeding, which they don't want to do.
Okay. Looking at two more right now.
Okay.
Which device seems to be the safest for the brain?
They're all safe. I mean, again, the FDA, their job is to find things that are safe and effective. Again, I was involved with the DBS, and again, I'm very closely familiar with the people that did the RNS. The VNS was actually done while I was training, so 20 some years ago, and all of them are safe. All of them are safe. I don't think that you say one is safer than the other. Now, the risk of surgery, if you do it on the brain, there are some risks. They're very small, but there are some risks of bleeding. There are some risks of infection. Of course, there's infection. You could get an infection if they put something here, but the risk of bleeding in the brain is higher, obviously, when you have brain surgery, but it's still a very small number. So in the hands of someone who has done this type of surgery, I don't think I want to be their first case that they've ever done. But for someone who's done this type of surgery, these are all very safe.
Okay. Let's see here, one or two more. Should I bring up the topic of devices to my doctor if I don't like medicine, or should I let my doctor bring it up?
I would say you should always ask questions. What's my next option? What are my choices? I think he or she should bring it up too, but if they don't bring it up, then why don't you? The answer is yes, absolutely. Bring it up.
Okay. That's all I'm seeing for right now. So if any of you have a question at this point, please submit it now. Otherwise, we're going to come to the end here. Any words, Alicia?
Again, thanks, Dr. Sandak, so much for your knowledge and all the visuals. I'm a visual person myself, so I thought that was really helpful to see all that. So thank you very much for your time this evening, and we really appreciate it. John, I don't see any other questions, so I just want to, before we end, I just want to remind people of that 3 questions at the end when we close. It should come up on your screen. If you do have a minute or two to just give us some feedback, we always appreciate that. Well, with that said, I think we'll close, and thank you, everybody. We'll see you next Thursday.
Have a great evening, guys.
Bye-bye.
Bye-bye.